All right, good afternoon, everyone. Thank you for joining us today for the South Texas Regional Family Medicine Grand Rounds. Next slide, please. Thank you in advance for being attentive to the presenters engaged in the session, registering for CME credit for each session, completing and submitting a session eval form, muting your microphone once the presentation begins, and keeping your cameras on when appropriate. Next slide, please. So here's the CME code for today. I'll leave this slide up here for a bit so you can all claim your credit. All right, next slide, please. And this is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the Grand Rounds will address today. Next slide, please. All right, and Dr. She has a brief introduction for us.
All right, it's my great pleasure to introduce Dr. Alexander Young, who is a clinical health psychologist with a diverse background in various health settings and systems. He has worked in academic medicine, healthcare startups, and governmental agencies, providing a variety of services and education. Currently, Dr. Young works at DHA, which I had to Google up, Defense Health Agency at Fort Belvoir in the Department of Surgery, providing education, consultation, program development. He's also currently providing consultation services to healthcare startups to help expand access to care. So Dr. Young is going to give a presentation on getting through the visit in psychological way, agenda setting in primary care, which is very relevant and important for primary care. We all know we go through the clinic in very hectic way. So without further ado, let's hear from Dr. Young. Thank you.
Hi, everybody. Nice to meet everybody virtually. Nice to be back virtually. I did my practicum at, the Brady Green Clinic, so it's nice to be there virtually at least. So we'll get through this presentation. So today we're going to be focusing on agenda setting and rapport in the primary care setting. So who has had the hand on the doorknob issue, right? I think based on the way I have my participant settings, I can't see y'all, but just think about it, right? Who has had this? It's a very common experience. It's something that I think everybody runs into, even very seasoned providers. Even as a behavioral health provider, I still run into this when I see people in medical settings or even in traditional settings. This is not something that's unique to medical settings, but it happens to kind of providers across the spectrum. So who does this, right? Again, think about yourself, think about the group that you are working with, the people that you work with. Who is doing this in their visits, right? I think a lot of people maybe think about doing this, try to do this, have the idea of doing this, but really think about, in your group, who's actually engaging in this skill. A lot of times, not as many as should be, right? And unfortunately, it leads to some detriment, some issues with patient care, and some issues with patient relationships, really. Why don't you do this, right? That's a better question. There's probably a lot of reasons, but I kind of picked 4 big ones. The first one is that we're never really taught how to do this, right? I think a lot of people are told about this, right? Like, why don't you agenda set? Agenda setting is going to be helpful for patients. It's going to help with time management. But I don't think that a lot of people get good kind of transparent education about how to do this activity or shadowing or anything like that. And it is a skill that sometimes has to be rehearsed, right? Kind of practice to kind of make it the best that it can be. It takes too long. This is a common fear for new learners, new providers, that this is going to take too long and it's going to eat up too much of their visit. And that certainly is possible, but that's why practice is important to kind of make this a very surgical skill in order to make it work very well and efficiently and seamlessly in your visit. Who knows where this will lead, right? That is it's like I open Pandora's box. Where is this going to go? That can certainly be a problem. And the last one is, I can't deal with everything they bring up. And you probably won't, and that's okay, right? That's why we work in integrated care. There are some things that can be handed off to other providers or other people within the clinic, but there may not be enough time to get through all of the things that are on their list, and that's okay, right? We can save those things for later on. That's the nice thing about agenda setting, is that we can kind of see everything on the table all at once and make important decisions based on what patients and providers are coming together to kind of negotiate. So from a provider's perspective, why bother setting the agenda? Well, one of the important things is actually time management, right? So if you only have 10, 15, maybe 20 minutes with a patient, time management is of the essence, right? Our visits need to be very structured. They need to be very delineated to what we're going to do and when we're going to do it. And agenda setting really helps give not only yourself kind of a roadmap for what are we going to start with, what are we going to end with, it also gives your patient a wonderful idea of how topics are going to be discussed, right? So they won't maybe interrupt you as much when we're first talking about diabetes. They won't interject things about their high blood pressure or their depression when we're talking about, insomnia or whatever it might be. It helps people to have a roadmap, not only for yourself, but for the patient, so the visits can go smoother, that they can anticipate what's going to come up, and they're not surprised by anything, right? They're not kind of caught off guard. Studies have shown that oftentimes primary care providers will hit that first topic, right? What brings you in today? And patients will usually tell you something, but oftentimes that may not be the most important thing. It's just the most comfortable thing they feel like they can discuss with you. But we oftentimes jump on it, right? Because that's the first thing they said. But more often than not, patients have a secondary topic or something that is more sensitive or more embarrassing or whatever you want to call it, that they might also need to discuss with you, but they're not comfortable enough to bring it up during that first few minutes, first few seconds of the visit. Engaging in agenda setting really helps to reduce or prevent hand on the doorknob issues. It doesn't fix everything. There are certainly patients that will talk your ear off and will have a laundry list of things, but on the average, right, engaging in agenda setting a lot of times can limit or reduce this kind of last subject in the visit experience for providers. It's also important, as I mentioned, to know all of the issues up front. As I mentioned, not all of the, not the most important thing will come up the first time, right? Sometimes it's the middle thing or the last thing. A lot of times, biomedical issues will sometimes be brought up about 50% of the time, but the other 50% of the time, they won't really talk about it, right? They may have a rash, they may have some kind of thing they're concerned about or whatever it is, but they may not, again, feel comfortable enough to bring it up that first time or kind of in that first kind of one or two items. It's even less if it's psychosocial, right? If it's something that's embarrassing, something that's stigmatizing, or something that needs time. So think about sexual activity issues, right? Anxiety and depression, domestic problems, physical functioning issues. Patients are often afraid to be labeled or to be treated differently because they may be experiencing something that is embarrassing or stigmatizing, right? So a lot of times people will do that thing of, well, doc, there's something else that's been bothering me, or, would you recommend medication for, erectile dysfunction or whatever it is? They'll kind of throw it then at the end, but those things need more conversation, right? They need more kind of just engagement to kind of figure out, where is this coming from? How long has it lasted? All of those important medical questions to really understand, should my patient be given this medication, or what options or interventions should we look at for this patient? So the other thing that's very important is this idea of rapport, right? So setting up this agenda really allows for us to join with our patient and join in a way that allows us to work together, right? Providers and patients often have different priorities. Patients are often very present symptom focused, right? I have a cold, I have a pain, I have some kind of physical issue that I'm upset about, and I want that issue fixed or attended to. But providers are often focused on reduction of future risk, right? You have elevated glucose, you have an elevated blood pressure. We don't want this to turn into something where you need medication. We don't want this to turn into diabetes, right? All of these things can cause issues, right, in visits. Symptoms may be important to deal with, right? But as the provider, you may be interested in treating those, but this other piece, whereas your patient may not really be that interested in working on future risks. Some patients are very health oriented and very interested in kind of mitigating that risk for themselves in the future. But a lot of patients aren't. Their motivation is on their current, present kind of acute symptom, whatever that is. So agenda setting can help kind of mix these topics together, right? Maybe the provider has one topic and the patient has two, provider has two, the patient has one, whatever it might look like. But it helps to kind of create this co-language priority list for what are we going to actually do during today's visit. Again, with complex patients, because, primary care is just home to so many complex patients. I feel like primary care gets all the people. There's nowhere else to go, really. And you see all these kinds of people, and 2/3 of the time, people will often agree, right? This is what we should be working on. I think that number is a little inflated. A lot of times patients just follow with what, their provider is saying. And so they just say, well, that's what you think is important. That's what we'll work on. Or they just kind of nod their head and smile. But the other third, or probably a little bit more, don't agree, right? They maybe are dissatisfied with their visit. They didn't like the visit. They didn't feel that they were heard or understood. And so that can cause rifts within that rapport, within that relationship that patients have with their provider, and ultimately it affects their care outcome. So from a patient perspective, right, providers don't always listen or understand their concerns, and this happens for a variety of reasons. Sometimes patients have a poor understanding of what their provider can actually do within the time constraints they have. Sometimes they're not articulating it well themselves. There's a lot of different reasons, but sometimes it can be due to this kind of poor interaction, right, during visits, right? Agenda setting can help reduce that. It won't fix it forever or fix it indefinitely, but it is something that can help, especially at the first part of the visit, kind of mitigate it or kind of make it a little bit better. One thing that oftentimes gets in the way is pursuing like excellence initiatives, right? So I want to focus on, like when I was at Brady Green, the big thing was Shingrix, right? Everybody was, Shingrix was a big thing that they pushed. But all clinics do this, right? There's something that they really want to push, a certain screening, certain vaccine. I was at the doctor's the other day, and the initiative was like tetanus shots. So a lot of times people can get very caught up on these hot topics, hot initiatives, and limit their interactions on other pieces within the patient visit. So sometimes when that happens, or when we're not kind of having a good relationship with our patient as far as communication, patients can feel like their appointment was a waste of time. I didn't get to talk about what I wanted. The big thing that I needed help, which is probably the last thing I brought up, wasn't addressed. So I wasted my time to come over here. They don't feel like they got fully checked out, right? Because again, their list of items was not fully discussed or even evaluated, right? We just stuck to the one topic, but I had to take off work, and I had to take the bus, and I had to do all of these things to get to my appointment. But of my list of 5 things, only one thing was addressed. Patient felt embarrassed to ask questions or to ask for help, right? Sometimes patients, especially patients from different cultural backgrounds, have a hard time kind of pushing back against authority, namely the physician, and asking questions, trying to iron out misunderstandings. What do you mean my A1C is a 7, right? What do you mean that I need to get lab work every 3 to 6 months? How is PT going to help my pain, right? All of these things can sometimes be difficult for patients to kind of come back to and ask providers if that relationship is not strong, if they don't feel that there's kind of that back and forth that might be present, again, with agenda setting being done in the beginning of the visit. And the last one is being listened to, right? Oftentimes patients feel like they're not listened to. Again, it's a compressed time visit, it's a compressed thing. And agenda setting, just by the nature of how you do it, allows patients to be listened to, allows patients to be a part of their care and included in the decisions that are being made right from the beginning. So why is it important? I've kind of mentioned this kind of throughout the narrative here, but when communication is poor, it really affects patients, right? Patients have worse outcomes. They have worse adherence. There's confusion, right, about what they're supposed to do, how often they're supposed to do it, when they're supposed to do it. You can be the best physician, but if you don't have a good communication style, if you're not able to reach your patients, they're not going to be able to benefit from your education. They're not going to be able to benefit from your interventions or the things that you're trying to get them to do. If you look back and you have a lot of patients that have non-adherence, certainly some of it may be due to other factors, right? Financial factors, psychosocial factors, other things. But if you take a look back, if you kind of slow down a visit, use a visit just for kind of ironing things out, it may be that there's a communication issue, right? They may not really understand what they're supposed to do or how they're supposed to do it or how they can do it for themselves, right? We assign different interventions, we assign different things to patients, assuming that they know what to do. And because people's situations are different for a lot of different reasons, they may not understand how to apply that to their situation or how to make it work. And so sometimes that can be important to kind of iron out as far as, again, working on that communication factor within visits. So the goals of the visit, right? So the first part is getting our job done, right? Creating a shared agenda. So understanding our agenda and our patient's agenda, right? What did the patient come to the visit to discuss? Sometimes it says on, the reason for visit. Sometimes it doesn't. Sometimes they say one thing and they come in with something different. One thing that I really liked at one of the medical practices I used to be at was that they had this agenda setting form where they gave it to patients that were sitting in the waiting room. It had 3 lines, and patients were asked to fill out what they would like to talk about, with the most important thing being first, and then second and third, with the physician before they saw them, right? And they had some other questions on there to kind of help speed things along. But it really did a great job to let the provider know, hey, my patient wants to talk about these 3 things, confirming it with the patient, making sure that those things are accurate, that you understand what they meant by what they wrote. And it worked really well. Now, some patients added a 4th and 5th and 6th and 7th line. Obviously couldn't get to all of it, but it was a really great, simple, low cost, low budget intervention that seemed to save the clinic quite a bit and forced providers to utilize agenda setting because it was on a form. It also kind of helped efficiency within the clinic, but a great simple idea that often can be helpful. The other thing with agenda setting is really negotiating what can and needs to be done in the appointment with a limited amount of time, right? Patients really don't understand the amount of time providers have with them. They understand that it's short, but they really don't have a good concept of, is this 10 minutes, 15, 20, 30? How much time do I actually have with my provider? Patients don't have a good understanding of that. Even patients that have good health literacy have a hard time understanding how much time do I have with this provider, right? Maybe my, gastroenterology provider is different, dermatology is different, nephrology is different. All of these providers have different time slots, different visit, times, et cetera. So how much time do I actually have with internal medicine, with primary care, with family medicine? What is this visit going to look like time-wise? Some authors recommend saying how much time an appointment is. I suggest you do it always, right? So, and here's a little script that's in here. So we have about 20 minutes together today. What's the most important to you on this list? Again, this goes back to this paper that I mentioned. But it allows patients to be informed that, you know what, I only have 20 minutes with my provider today, and that's why we're focused on 3 big topics or 2 big topics or whatever it is. It really helps patients understand kind of the confines and why we can't talk about 10 things or 20 things or all the different things that they want to do. The relational aspect of a visit, right? So developing a therapeutic relationship, developing some kind of connection with your patient, even if that connection isn't robust, as long as the patient feels that there is some kind of connection, it really lends itself to kind of better outcomes and better adherence. When there is a therapeutic relationship established with a provider, patients often feel listened to, respected, and they participate more in their care. They're more likely to tell you that there's a side effect or that there's something wrong with their medication or that they don't understand instructions, right? They're more likely to come back and say, you know what, I don't really understand what an A1C is. I don't really understand how my inhaler works, right? I don't really understand why my diabetes medication, makes my blood sugar go up and down, right? They're more likely to kind of ask those questions and not be kind of stuck on Dr. Google or getting advice from their friends and showing up when things are maybe not going so well. The last one, as I mentioned, is decision-making and education. So it increases understanding and buy-in, again, to get the patient to just be more adherent, but to have better outcomes, not only for their own health conditions, but just for your interactions with them. So this is a really dated article. I apologize, it's so old. It's from 1999, back in the 1900s. Somebody reminded me of that the other day. But in this study, physicians solicited concerns from their patients in 75% of the interviews that they had. This sample was very small. I don't remember how many patients, but it wasn't huge. But only 75% of the physicians solicited concerns, right? That's not very much, right? The other people just kind of went on what the chart said or kind of what was in the appointment. Patients' initial list of concerns were only completed 28% of the time to 100%. Physicians redirected conversations after about 23 seconds. Now it sounds very brief, but 23 seconds is a fair amount of time. But if patients were allowed to complete their concerns to 100% to completion, it on average took about 6 more seconds for them to kind of complete their list. Now, this is in a kind of an ideal perfect situation, right? This is with redirecting patients, with kind of saying, okay, sounds like you're having some issues with depression. Is there anything else on your list, right? Some structure to that giving of information. But 6 more seconds is what it took to kind of make this a completed list. And when that happened, you can see at the last piece, patients that didn't complete their list had at least one common, late rising concern 35% of the time. If they were allowed to finish those extra 6 seconds, it only happened 15% of the time, right? So while that's only a 20% difference, that's quite a bit, especially if you see a lot of patients over your day or your week. That time adds up, right? Those minutes add up. And it often, again, has so many benefits to letting patients kind of share with you what's going on, what they want to talk about, that it really is kind of worth it in the end. So if anything, right, agenda setting will save you time. It doesn't seem like it up front, just because of how it works or kind of how we set it up, but it really can with practice, and it can ultimately lead to this kind of reduction in kind of late rising concerns or kind of hand on the doorknob phenomenon. So some other aspects of setting the agenda. So one of the things that I often hear, even from my own providers, is what brings you in today, right? And that kind of gives you that first concern, which is helpful. But again, patients may not give you the most presenting concern. And a lot of times patients have more than one concern. So it can often be helpful to keep asking what else, right? So, okay, you're here for, sinus infection, right? What else? Any other issues you'd like to discuss today? And you're continuing to ask that, what else? But it's important to also remember that you may have to engage in some interruption, right? You don't want a laundry list of just, I'm here for depression and let me tell you about when it started and all of these things, right? We don't necessarily want that to happen. So it might look like something like, I'm here for a sinus infection. What else brings you in today? Well, I have some depression. And then they may give you a little bit of information, then interrupting them and saying, okay, so I'll put a bookmark in that for right now. It sounds like depression is something you want to talk about. What else, right? Okay, and then kind of using some surgical intervention to interrupt so that patients don't go down a rabbit hole of just stuff, which they can, to get as many items that the patient wants to talk about. It's often recommended not to start going into things until everything is out, everything they want to kind of bring to the agenda. And it's important to remember, as I mentioned, that most important thing may not be at the top of the list. So once we have that, right, once we have a good handle on kind of what they want, it's important for you to say what you want, right? We want to talk about diabetes, high blood pressure, insomnia, asthma, kidney function, right? Whatever it is. What are my concerns or my big kind of ticket items that I want to talk about? So we have your list. And then what are the most important patient tasks, right? Paperwork, refills, imaging orders, lab orders, things that need to be done kind of present day in the moment, and starting to put those things together, right? I know that this is kind of spelled out and it sounds long, but again, with practice and in the moment, this actually doesn't need to take that long, right? A lot of times we walk into our visits having pre-read the chart or kind of awareness of kind of what the patient is, their medical history. And so we may already know, well, I need to check this patient's A1C, or their A1C was super high, or, their COPD is not being well controlled with their medication, whatever it is. So a lot of times those clinician concerns are known ahead of time, but it's those patient concerns and those kind of important kind of today tasks that oftentimes have to be kind of negotiated or kind of figured out in the moment. So at least 1/3 of this is kind of taken care of to a point. So what can be attended to, and what can be postponed for future visits, right? So this is really where you and the patient prioritize and negotiate an agenda. Respect for the patient's needs, kind of what they think that they need kind of in the moment. An efficient discussion about kind of what those things are and what we can do. And then checking for understanding and agreement, right? Sometimes patients talk about certain things or they'll write certain things down, and it's not exactly what they mean, right? They may say, oh, I have a pain. Well, that pain may actually be depression, or that pain may actually be something completely different, right? Maybe they just didn't explain it very well. So checking back with a patient to say, you know, it sounds like you're mentioning pain in your arm. Is that from an injury? Is that something that kind of happened, you know, due to whatever it is? When did this kind of start, or when did this kind of come up? It doesn't have to be a long conversation, but just kind of a quick snapshot so that you know, maybe this isn't just an injury, maybe this is some other kind of thing, maybe related to something else or a psychosocial issue. The last thing is, what if future negotiation is necessary, right? So there are items that you can't get to, right? And the nice thing about integrated care, the nice thing about kind of being where y'all are, is that you don't have to do everything, right? If the patient comes in with 10 items on their list and you can only get 3 done, and I wouldn't recommend really doing more than 3 in a visit unless you are ultra efficient and think you can, utilize the behavioral health provider, utilize the pharmacist, utilize the dietitian, the caseworker, the social worker, the medical assistant, whoever. Utilize these individuals to help maybe take care of some of those other items on the list, right? Patients often have to take off time from work. They oftentimes have to you know, travel. Maybe it costs them money to get to their appointments. And so a lot of patients really want to get the most value out of their visits that they can. And we can help do that, right? As the kind of the captain of their ship, you know, as the medical provider, you can direct these other people, these other entities within the integrated system to assist the patient in getting as much done as possible for that first visit as you can, right? And that's the nice thing about agenda setting, right? You get to know these are all the things that the patient needs help with. And these are a lot of things we can check off. But at the end of the day, if we can't, it's okay, right? We can put those things in the note. We can kind of put those things on a little sticky note within the patient's chart or whatever. And the next time they come in, we can kind of revisit it and say, hey, you know, we didn't get to number 5, 6, and 7. Are those things still problematic? Are those things you're still having issues with, right? And we can kind of work off this kind of living document as far as these are the things my patient is bringing me. These are the things I'm helping with. And these are the things we can kind of come back to, right? It really creates this nice back and forth and dynamic relationship between you and a patient, and really just working on the things that they need to work on as life progresses. So it sounds easy. I think it sounds hard, honestly, but it can be difficult to do in the moment, right? It can be difficult to do something else than we're used to doing. A lot of times we get into routines, right? We're used to coming into patient visits in a way where this is what we do, this is how we do it, and then we leave, right? And when we introduce a new skill like agenda setting or shared decision-making or motivational interviewing, we have to kind of think about it, right? We have to think about, how does this fit into my clinic flow? How does this fit into my visit flow, right? But it is something that will save you time. It will improve your patient outcomes, and it will really improve that relationship that you have with your patient in this setting and in any setting that you kind of move forward. I work in the surgery department, and we use agenda setting all the time. It keeps things going well. It keeps things very efficient. And it really just creates this really nice dynamic, like I mentioned, between the provider and the patient. The next thing we'll talk about here is rapport. I have a definition of rapport here. There's a lot of definitions for rapport, but this one is for therapeutic rapport, which I think still applies to medicine, but is an empathic shared understanding of a problem's or perspectives in which the primary goal is to use this understanding to collaboratively develop solutions to a problem, right? I think that applies to most people, most providers, most situations. But it is important to kind of think about rapport and your interactions with patients and what it looks like. So again, a question for the group for you to kind of think about is, how do you define rapport for yourself, right? Do you use this type of definition? Is there another kind of definition that you use for how you describe rapport or what it looks like to you? But the other thing to kind of think about is, what tells you that you have good rapport with your patients? And there's a lot of different studies on this, but a lot of studies show that providers, not just medical providers, just providers generally, are not good at assessing their own rapport with patients. But it is important to kind of look at, how do you assess good rapport, right? Do you look at body language? Do you look at eye contact? Do you look at clinical outcomes, right? Well, my patients have good rapport if their symptoms are improving, right? What do you look at as far as, this is a good indicator that I have a good relationship with my patient, that I've developed a good relationship with my patient? It's not something that we really think about, but it is something that we really should think about and really should investigate for ourselves to kind of really understand, what does this look like, right? If I'm not doing this, if I'm not looking for this, maybe I need to create some anchor points. Maybe I need to create some things for, this seems to be a good indicator. This seems to be something that really tells me that that relationship is strong, et cetera, right? Maybe patients are more transparent with you or able to ask questions or whatever it might be. But it is something I would challenge you to kind of think about and ask yourself, what do I do to kind of notice or kind of try to figure out those patients that have good versus not good rapport? These are different relationship models. They are not exhaustive. There are many, many relationship models. These are kind of the three most salient ones. The first one is kind of a passive-active model. This is like emergency department trying to keep you alive, doing everything they can to just keep you breathing type of situation. Not too, maybe, well, I guess it might be representative in the providers in this visit, but that's kind of by itself. The next one is more common, and I feel like it's a little more archaic, but it certainly is still prevalent. So a doctor is placed in a position of power due to having medical knowledge, and the medical doctor makes recommendations, and the patient is expected to comply, right? I expect you to get your labs because I said to. I expect you to exercise because I said to. I expect you to take your medication because that's what I've recommended, right? Over time, I think this has changed to be more equal, more kind of a back and forth. But I have still seen this in clinics I've been in for training. I have seen this in my own experience with my own providers in the past, where I'm being dictated to what I should be doing for care. It doesn't go over so well, right? A lot of patients, especially newer generations, really buck this experience. They really don't like it. Older generations are more likely to kind of comply or be complacent to this type of relationship. But younger generations really kind of buck this experience and really just find it negative. I've talked with some patients in other training clinics I've been in, and it just across the board seems to be something patients don't like. The one that is more kind of, I guess, up and coming or just more equal is kind of this mutual participation model, which is the idea that there's an equal partnership between the doctor and the patient, right? The patient is viewed as the expert in their life, their ability to do things, their resources, their experiences, and the physician is meeting the patient's goals, even if they're not the provider's goals, right? So as an example, maybe the patient has diabetes and high blood pressure, but the patient is really just interested in treating their high blood pressure, right? That's where their motivation is. That's not to say to give up on the diabetes care, right? Because that's certainly going to be a problem later on. But their motivation, their drive, their kind of focus is really on the high blood pressure piece, right? So if that's where they're at right now, that's where we need to really focus, right? We may ask some questions, put some educational injections here and there about diabetes, but if the patient's goal is not to really focus on that, control that, have it under, where it should be, then we're kind of, beating our head against the wall, right? We can prescribe the medication, offer the referrals, do all of these things, but if they're not engaged, if they're not motivated in that care, then they're probably not going to do it. Or if they do it, they may not do it very well. So this idea of mutual participation model is really the idea of trying to meet the patient where they're at and kind of build from there, hopefully to hit everything, but a lot of times it may be kind of slow, right? Working on what they think is the most important thing while giving them some more education and information. This is a graphic that I like from a study that's kind of dated as well from 2008, but it kind of goes through the different pieces of a medical visit or just kind of a visit in general, right? So the first part here is establishing focus, being upfront, collaboratively agenda setting on what the visit's going to be about. Again, using that something else or what else. Of these things, what is the most important? And aligning expectations, right? Within 20 minutes, I think we can talk about 2 topics, 3 topics, right? Patients that are very talkative, right? Maybe it's just one topic, but aligning expectations on, it sounds like 2 of these things you really want to work on, and then 1 of these things we really need to talk about, right? Because this is something that's really going to be impactful in the future, or something that, you know, might be overlapping with what they have as what they've decided. So aligning those expectations. The second part here, eliciting the patient's perspectives, right? Being curious about how they see their condition, how they see kind of culture or other family influences going on, right? You know, I think about this a lot of times for patients that we want to lose weight and kind of our expectations for them to cut calories, to reduce food choices, to eat healthier, right? Sometimes it can be important to ask these questions of, you know, how does food work in your family, right? How does food work during your home life, right? Whenever, you know, in your typical week, who does the cooking? Who does X, Y, and Z? You know, what are your thoughts about changing rice to quinoa or reducing rice to cauliflower rice, right? All of those things can sometimes be very helpful in trying to figure out barriers or other issues that might be going on as we think about intervention for patients. And then lastly, co-creating a plan, right? A plan that hopefully incorporates their kind of understanding, their beliefs, inviting patients to ask questions, because as we know, patients will not ask questions oftentimes, even though they should. So inviting questions at the end of a visit, and then allowing for time for adjustment, right? You know, at the end of the visit, if a patient says, I don't think I can stop eating rice, right? I don't think I can take insulin injections because I don't like needles. I don't think I can get my lab test because I can't afford the bus fare, right? Allowing time at the end to kind of make this adjustment so that things can you know, run a little bit smoother. But all of this, again, starts with this idea of collaboratively agenda setting, right? It really sets the tone for the whole visit and allows the patient, again, to just understand what's going on piece by piece. Some just basic rapport things. I think people are okay at rapport building, some people better than others, but rapport is often created faster than you think, right? Especially in this day and age of technology, most people Google their physicians before they even see them. So they have a preconceived notion about who this person is. I often Google my providers right before I go see them. Does this person have a high rating, a low rating? What have patients had issues with this provider, right? So it's important to realize that when you're coming into a visit, you may be climbing a hill because somebody sees something online, or you may be sliding into home base because people think that you're the best doctor on the planet, right? But rapport often starts even before the visit starts, right? Those building blocks, sometimes not so well, sometimes they're already built in a good way. But think about your own medical experiences, right? When you've had to go to the physician yourself, whether it's specialty care, primary care, internal medicine, think about your relationship with your provider, right? When did it start? Has it gotten better? Has it gotten worse? Has it stayed very neutral? What has that looked like for you, right? Because this varies from person to person, but it is important to realize that this is something that starts even before the patient gets in the room. One thing that I always encourage is to greet the room, especially in San Antonio or other places that have kind of different cultures or different communities. A lot of times people will bring their family, their spouse, or somebody that we think is their spouse, but it's actually their sister, cousin, brother, aunt, uncle, whoever. But they might be giving you medical information, right? But we don't know who they are. So saying hi, trying to get everybody's name, trying to get who they are in relation to the patient. Again, a very simple, basic rapport building thing. Oh, my provider's interested in knowing who I'm with today, right? Trying to call people by their name, that's very difficult. I'm not the best at remembering names, but you know, that can sometimes be helpful. Smile and use direct eye contact. In the age of computers and concurrent documentation, it is important that we look up from our computer. It's important that we take time, a few seconds, a minute, to step from behind our computer or to kind of wheel over a little bit to just have a conversation with our patient, to engage our patient in a meaningful way without the computer screen kind of being in between us. Glancing over, the occasional eye contact, the occasional smile, again, can do a lot of wonders in medical care that is increasingly more technologically heavy and is, again, creating a lot more distance from patient and provider. And then the last thing that I think really goes really far, and it's something that I look for when I see my providers, is investment, right? Are you asking me about stuff, right? Are you asking me about my day, about plans that I have after the visit, about things I like to do? This doesn't have to be a full-blown conversation. This can be when you are signing into your computer, right? When you're getting the patient's note up, when you're typing or whatever it is, doing some other kind of lab order or whatever. How are you doing? Did you do anything fun today? Are you doing anything fun this weekend, right? It can mean a lot to patients to ask those really small kind of investment questions. And I often encourage learners to kind of put, with like Epic, I think there's a sticky note feature, and a lot of the other EMRs, there's a sticky note feature where you can kind of put, Billy Bob likes sports, Billy Bob likes baseball, or, whatever it is. And it allows you to kind of build on that, right? The next time you see them, have you seen any good baseball games recently? Or have you gone to the lake recently, or whatever it is? That can show that, you remember the patient. And for a lot of patients, that can be very reassuring. It can be very warming to know that their provider remembers something about them, that they're not just a number, that they're not just the 3 p.m. appointment with diabetes or whatever it is. But it's the small things that really help rapport build and grow over time with patients. This one, just communicating warmth and compassion, showing courtesy and respect, reflecting and listening. The one thing I want to highlight on here, which is probably a whole nother presentation, is shared decision-making. Shared decision-making often goes with kind of including patients in their care. It is another thing that can cause a time suck if it's not done well, or is not done in a structured manner. But shared decision-making also can make patients engaged in their care, produce better outcomes, better adherence. But offering more than one option can oftentimes be a simple way to engage in some shared decision-making, right? We can start you on metformin or, whatever it is, or we can, do this medication or that medication, or we can try lifestyle or, a low dose high blood pressure medicine or whatever it is. But offering 1 or 2 options, right? 1, 2, or 3 options or whatever it is, so the patients understand or realize this isn't the only thing I can do, right? This is the one thing that's being recommended and there's not other options. Patients really don't have a good understanding. I have come across a lot of patients that will say, well, my provider only said this one thing or this one medication or this one procedure. I didn't realize that there was something else I could do. There's something less invasive or lifestyle management or whatever it is, because I wasn't given the choice, right? Some patients don't have the health literacy to understand that or act to look for other options, right? So trying to put that in just a little bit here and there, don't have to do with everything, can just help kind of, put in shared decision-making a little bit. This is another model for rapport over time. This one is a little more psychological in nature, but the idea with this here is just establishing rapport with a patient over time, understanding kind of a patient better, understanding their needs, moving to try to limit or mitigate conflicts, right, that may be arising within the medical system or within the patient's access to care. And over time, this can lead to patients having barriers, their barriers to care will be decreasing, hopefully, and they'll have an increased sense of connectedness to care, right? So I feel like I can reach out to my provider. I feel like I can access care in a way that is meaningful to me if I have questions, concerns, et cetera, or if I need my provider to put in a referral. And over time, it leads to sustained engagement and care, and really can just help, again, patients feel that this is the system I want to be in. This is the system I want care from. this is the clinic that I want to come back to because I have such a good connection with my provider and such a good connection with this health system broadly, right? So rapport and agenda setting, they often go hand in hand. But since primary care for a lot of patients is kind of that first door to care, it can go a long way for having patients to have a provider that they feel close to, they feel connected to, they feel they can come back to if something isn't going right in their medical journey or if they're having struggles with accessing care in other parts of the health system. So this is the practice thing. I'll actually skip this, but this is something I did with another clinic presentation. But I would encourage you to practice agenda setting with a peer. Certainly agenda set, you can try it solo in your car, wherever you want to do it. But I really would encourage you to try practicing it first, trying it with some patients. It's okay if things don't work well the first time or even the second or third time. It's really about trying to figure out, how do I finesse this for myself, right? How do I make this doable for my visits, the way I like visits to proceed, and the way I like to engage patients, right? How can I make this work for me? So I would really encourage you to kind of work on that and really, develop it in a way that feels doable and kind of produces those results as it relates to kind of patient relationship building, patient outcomes, and just overall a better patient and provider experience. And that's it.
Dr. Young, thank you. This is Dr. Johnson Esparza Yahaira here. Thank you so much for joining us today. I think we're waiting to see what questions folks might have. But kind of adding to your last point, I think I have a question. I'm thinking about folks who might be in this talk and thinking, okay, yeah, great, agenda setting sounds wonderful. I have 7 patients a clinic, 10 patients a clinic. How do I even start doing that? I'm going to definitely go where I have this many patients. And I know the data says it adds a few more seconds, but what recommendations do you have for someone who is wanting to start implementing agenda setting? Do they just go ahead and practice with every single patient, or what recommendations do you have so they can slowly start building that skill?
Yeah, I would definitely encourage starting with just 1 or 2 patients, right? You don't want to try this with every single patient, especially as you're first starting. It may add a lot of time to your visits. And as you're trying to figure out, again, what works, what language do I use? How do I interrupt patients that are trying to add too much to their, their agenda items? So I always encourage learners, try to do this with maybe 1 or 2 patients, preferably maybe not like back to back, right? Do it with your first patient, maybe your 3rd patient or 5th patient or whoever. And then over time, as you start to kind of finesse it, as you start to kind of smooth out those bumps or those barriers, start to add it to more patient visits, just slowly over time, so that, again, you can see what works, what doesn't work, and hopefully not, again, add to that time burden that can sometimes come with, new skills or new things that you want to put into visits.
Great, thank you so much for that. It's one question that I think comes up often. What other questions do folks have for Dr. Young during his homecoming grand rounds? All right, well, I don't see any questions coming up unless my chat is just not capturing them. But thank you so much, Dr. Young. We appreciate it. I think it's a very important topic. It's definitely a challenge for us behavioral health consultants as well. Can be very challenging for all of us to do that. But we appreciate your time and sharing your knowledge with us. So thanks a bunch, everybody.
Thank you so much.